Hello guys, welcome to the clinical scenarios and this is your case number 31. So here we have a 65 years woman presenting with the complaints of pain and swelling over the inner aspect of her right eye. Inner aspect means towards the middle canthus, and this pain is for the past 2 days. So there is a pain, there is a swelling in a 65 years female, and that too over the middle canthus, and that is of acute onset, right? Now examination of the eye reveals tenderness, edema, redness over the medial canthus. So same area where she is having pain, on examination there is tenderness also, swelling, that is edema is there, redness. So this means that there is some inflammation there, right or not? Because these are the signs of inflammation. Right from first year, second year, you people read these signs that there are 5 major signs of inflammation in pathology, and now it is the clinical application. We have tenderness. Tenderness like usually indicates that there is some pus or there is some infection there. Redness is also a sign of inflammation. Edema is definitely a sign of inflammation. Now on putting slight pressure over this area, there is also expression of the purulent material. See, they have confirmed this fact also, that usually when you have tenderness, you have redness, you have edema, it could be a pus forming infection. And they are saying also that when we are actually putting the pressure over this medial canthus area, then there is a purulent material. So visual acuity, then they have talked about the visual acuity, that is normal. What is the most likely diagnosis? So you have to search for a diagnosis which is occurring in a 65-year female, which is of acute onset, okay, which should be inflammatory, and it should be, the pustular. It should be some infection which is characterized by inflammation as well as the pustular inflammation. It's a purulent inflammation over the middle canthus of a right eye, which is not affecting the visual acuity. So what could be this? Now if I say that, tell me about a swelling over the middle canthus which is of acute onset, pustular, not affecting the vision. So I think the first thing that you will say will be your dacryocystitis. Yes or no? First thing that comes to our mind is the dacryocystitis. But the problem is that here you have 4 options. That is a good thing also, because you have the horizon to think. You have to think amongst these 4 causes. What they have given? They have given you dacryocystitis, hordeolum, chalazion, and orbital cellulitis. But sometimes what happen, that due to overthinking, we start thinking, ma'am has said that read every option carefully and every option could be the answer. So what happens? Dacryocystitis is the first option. Yes, that is correct. But second, hordeolum. Then you start getting confused. Hordeolum is also pustular, right? It is also of acute onset. Can this be hordeolum? Can it be a chalazion? Can it be a orbital cellulitis? So I will tell you how to go through this type of question where answer is not that difficult, but you tend to get in dilemma within the options. Okay. So I'll come to the dacryocystitis now in the last. Let's talk about the hordeolum. Okay, so when this word is given, hordeolum, what do you have to think? Hordeolum is also, acute suppurative. This is also acute suppurative inflammation. So sudden onset is there, pustular is there, but it is actually found in the lid margins. So hordeolums are found on the lid margins. How many types of hordeolums do you know? We have a external hordeolum and then we have the internal hordeolum. So how both of them are different? External hordeolum is also called as a stye. I think this is the most common thing that everyone must have faced in one phase of life or the other, that we have some pus pointing. Okay, here we have some pus which is pointing towards the lid margin, towards the lid margin. So it is actually pointing outward. That is why it is called as external hordeolum, right? While if I have the same pustular swelling and it is away from the lid margin, away from the lid margin, then I will say that this is a internal hordeolum. Okay, so first thing is that here the pain is not lying over this medial canthus. The area is quite different. This will be found in the lids. Now in the lids, one is towards the lid margin pointing outward, okay, you can see it, and another is internal. So only when you invert this eyelid you are going to see this hordeolum, okay, but person will start feeling some heaviness, pain here, because you know from the inner side this pus is pointing and it is actually causing the pressure over the cornea, and cornea has a high sensory distribution. Okay, now second important thing is that they have given that when they are putting the pressure, we also have a purulent material coming from this medial canthus. So here we don't have the expression of this purulent material from the medial canthus. No, it will be from this pus points. One is towards the lid margin, another is away from the lid margin. Yes, visual acuity again will not be affected by these also. Okay. Second important thing, if you look at the glands in which they are occurring. So as far as your external hordeolum is concerned, these external hordeolums are occurring in the glands of the Z's and the mole. Even these are asked as a separate MCQs also, which glands are affected. Now sometimes there is a confusion that both of them are given, then which one to choose? Then you have to choose this Zeiss gland only, because the mole gland ducts are also opening into the Zeiss glands. So even if both are given, then you have to choose this Zeiss gland. Now this is actually a sebaceous gland. Again a important MCQ, this is a sebaceous gland, while this mole is a sweat gland. Okay. Now if I talk about the internal hordeolum, internal hordeolum is occurring in the meibomian gland, meibomian gland, and you know meibomian gland is also a sebaceous gland. It is also a sebaceous gland. So we are very clear about this hordeolum. So answer is not the hordeolum. Coming to the next one, calazion. Now why it is not calazion or why it is calazion? First of all, understand what is actually calazion. Calazion is again a lid infection. So this is not occurring on the medial canthus of the eye as it is given. This is a calazion. So this is a chronic granulomatous. It is not an infectious condition. It is granulomatous inflammation that you are getting, chronic granulomatous inflammation. And what is the material that you are getting there? That is actually not pus. It is a non-suppurative condition. Sometimes they also give you true and false type of questions, which of the following statements is true about this or which of the following statements is false. So all these are assertions you should know. It's a chronic granulomatous inflammation, non-suppurative type, And to be very, very specific, it is a lipogranulomatous kind of inflammation. So the material that you are getting is lipogranulomatous, and it's a chronic condition. And in the question what you are being given, that was a sudden onset, a purulent condition that was, okay. So this is entirely opposite. This is a chronic condition, callus-eon lipogranulomatous inflammation, and it is not painful. It is not painful, rather you get a nodular swelling. You are getting a nodular swelling over the eyelids. And what happens, sometimes you have the multiple callus-eon. You can also have the multiple callus-eon. So due to this multiple callus-eon, there can be like dragging of the eyelid. So this can lead to the mechanical drooping of the eyelid, called as the mechanical ptosis. This is called as the mechanical ptosis. So in a way, it can cause the problem with the visual acuity, because you know it is causing the drooping of the eyelid, so it can even cover the pupillary axis. And another important thing is, when I have a big callus-eon or I have the multiple callus-eon. If I have a big callus-eon or a multiple callus-eon, then this can also lead to the astigmatism. This can also lead to the astigmatism, because this can cause the pressure over the cornea. So I cannot be sure that this will not affect the visual acuity. So I think this is now very, very clear that this is not the hordeolum and it is not the callus-eon. Now if I talk about the age of the lid infections, so whether I talk about the hordeolums or whether I talk about the callus-eon, what age we are mostly thinking of? So either it is common in the children. These lid infections are common in children like school age or preschool age, when they are actually doing more of near work, okay. And they might have the refractive errors due to the uncorrected refractive errors, due to the uncorrected refractive errors. So in children, this is one of the most common cause that you are getting the lid infections, because they have uncorrected refractive error, and especially it is the hypermetropia. So because you know all the babies are hypermetropic at the time of birth. Now if they remain undercorrected and they remain hypermetropic even after 5 to 7 years, and they are being not corrected by the spectacles, what is happening? They always have a problem of near vision. So when the children constantly have a problem of the near vision, they'll try to accommodate more, they'll try to converge more, and due to that there will be a lot of watering. There will be lot of watering from the eyes. Now what will happen? If there is lot of watering, the child will do the eye rubbing, and due to this eye rubbing, the chances of infections are very, very high. I think now you got the cycle. That is why most of the children that comes to us in the OPD who are having the uncorrected refractive error actually are not coming with the problem of vision. They are coming with the recurrent lid infections. They are coming with the problem of eye strain, astronomic symptoms, watering, redness. And this you should know then, that if the child is coming with this complaint, the first thing you should do is actually the refraction. And you know, hypermetropia has so many components. What components we have? We have latent hypermetropia, we have the facultative hypermetropia, then we also have the manifest hypermetropia. So what are these? Manifest hypermetropia includes two kinds. One is this, your facultative, and another is your absolute. So what happens? Some amount of hypermetropia can be corrected by the ciliary muscle. So that amount which can be corrected by ciliary muscle, about 1 diopter, is your latent one. The remaining is manifest. Now this manifest hypermetropia could be facultative or it can be absolute. So facultative means which is corrected by the patient's accommodative effort. Patient has been corrected by the inherent tone of ciliary muscle for 1 diopter. Suppose he had total of 5 diopters of hypermetropia. Now 1 diopter is corrected by the ciliary muscle tone. Remaining is 4 diopters. So what portion of this 4 diopters he can correct by putting that extra accommodative effort? Maybe suppose 1 diopter is this, maybe 2 diopter. Okay, this is just example. Then what is left? Remaining 2 diopter will be absolute. So total, if I talk about total, then it is 5 diopters. So if you want to find out the total amount of hypermetropia, so that none amount of hypermetropia remains undercorrected, uncorrected, because if some amount of hypermetropia remains uncorrected, then the patient will become amblyopic for that amount, okay, and amblyopia can lead to squint. There can be deviation. So it is very, very important that the hypermetropia should always be fully corrected. So that was the extra information that you need to know about the lid infections and the hypermetropia, how you have to give the treatment, how would you you can say work up the patient, especially the children who are coming with the lid infections. Now the other age group in which you are going to get this lid infections is the elderly people. So elderly people like more than 60 years of age can also have this, like we got this female 65 years, but it is more common with the diabetes mellitus, because you know diabetes has this propensity of decreasing the immunity, more chances of infection, decreased wound healing. All these things are there. So if an adult is coming with these things, the first thing you should rule out is always the diabetes. Okay. Then the fourth that they have given is the orbital cellulitis. Now why this is not orbital cellulitis? Now I think orbital cellulitis is one condition that can mimic very, very closely to this dicryocystitis. We can have the swelling near the medial canthus, because cellulitis means that you are having the infection of the tissue anterior to this orbital septum. Okay, when it is pre-orbital cellulitis, and when it is going beyond posteriorly, then it is orbital cellulitis, and usually the presentation is very, very acute, it is severe, it is having redness, it is having purulent inflammation. So it is very, very closely related to this dicryocystitis. One may get confused, and even it also mimics the cavernous sinus thrombosis. So that is why orbital cellulitis is important. See, orbital cellulitis is important not because of it. Orbital cellulitis is important because it may be mimicking the cavernous sinus thrombosis, it may be mimicking certain other conditions. So you have to understand this orbital cellulitis is the most common cause of unilateral. It is the most common cause of unilateral proptosis, and that too in children. So that means the most common age group where you are going to get this orbital cellulitis is not the elderly people, it is the children. So that is the very, very first thing that is going against it. Okay. Second thing, they have said very, very clearly that the visual acuity is not affected here. Now I agree, even on orbital cellulitis the visual acuity may not be affected in the early stage, but in the later stages, because you know the presentation is so much diverse. We have proptosis, we have chemosis, then we also have ophthalmoplegia. We can also have the ophthalmoplegia. Ophthalmoplegia means there can be paralysis of the extraocular muscles because of the involvement of the nerves. There will be the limitation there will be limitation of the ocular movements, right? So you are going to get so many things apart from just the pain here. We are getting so many things. It is actually more commonly a DD of proptosis. When you have to analyze whether this proptosis is due to the orbital cellulitis, cavernous sinus thrombosis, keratoconus fistula, orbital apex syndrome, pseudotumors, thyroid eye disease, then you get to know that what is actually the presentation of this orbital cellulitis. You know, it is not an emergency condition as compared to the cavernous sinus thrombosis or keratoconus fistula. So now you come back to the question and see, this is a 65-year-old woman. She is presenting with pain and swelling over the medial canthus from the last 2 days. Examination is also showing tenderness, edema and redness again over the medial canthus, and the slightest of the pressure is leading to the expression of purulent material, visual acuity normal. So now you are very sure that this is a case of acute dacryocystitis. So answer to this question is acute dacryocystitis. So I hope now you got the idea how to analyze the different options and reach to the final diagnosis. In case of any doubt, you people can always ping me up at any of the social media platforms. You can follow me on Instagram, visit my Facebook page, and can be a part of our huge family on Facebook group as well as Telegram group. You can take the advantage of the daily quiz that we conduct on the Telegram group, so that you get to know the different kind of questions, the clinical questions, the doubt solving sessions, and regularly you can ask your queries. Any feedback, any valuable suggestions are always welcome. If you want me to make videos on any other topics, you can also write in the comment section below, and do tell me how do you like the session. Thank you and happy ophthalmology.